Thank you for attending today's discussion. I'm Dr. Beth Barron, an internal medicine physician and educator at the Vagelos College of Physicians and Surgeons. Today I'll be discussing my role as the course director for Foundations of Clinical Medicine tutorials and some of the teaching initiatives that we piloted this year in response to the pandemic. This course occurs weekly during the second and third trimester of medical school and is focused on teaching clinical skills such as patient interviewing, communication, physical examination, note writing, and oral presentation. The course is interactive and hands-on. Prior to the pandemic, all sessions were taught in person, utilizing small groups with clinical faculty. Much of the course occurs in our simulation center in our medical education building. We have numerous rooms that are designed to appear like a physician's office and are equipped with video and sound recording. We design patient cases that connect to the content being taught in other classes. We train actors to portray patients presenting with specific medical concerns and include communication challenges for students to learn from. Examples include a patient presenting to the emergency room with palpitations or coming into their primary care office to discuss quitting smoking. Students are asked to interview and examine these patients, and they're assessed on their history taking, physical exam, communication skills, as well as their medical reasoning with note writing after the session summarizing the encounter. We have one-way glass and headphones that allow for peers and faculty to observe the student performance. In addition to these simulated patients, students are given the opportunity to practice these skills on actual patients. Patients volunteer to participate in this activity, and students are brought to the hospital bedside with faculty members to practice their clinical skills. In mid-March of 2020, the pandemic was surging. It was no longer safe to have students and faculty gathering in the simulation center or the hospital. The school made the decision to switch to a completely virtual learning platform, and students were sent home. Our old model, simply put, was obsolete, and we needed to adapt quickly. We were able to salvage the previously planned simulation center cases and quickly develop new ones to be substituted for the planned time with actual patients. Standardized patients could still be trained to portray the cases, but now, instead of the students meeting live in person in the center, we transitioned to a Zoom format. Faculty members would meet 4 students in a Zoom room with the trained actor. Students would take turns interviewing the patient and providing each other feedback about their history-taking process and communication skills. Students were still able to submit a note summarizing the encounter for evaluation after the session. Drawbacks to this new format included there was no ability to do a physical examination. Communication skills such as eye contact and body language are much more difficult to accomplish and assess over Zoom. And the lack of real patient interviews was challenging. Simulation can lack true authenticity and complexity, which limits their usefulness. There were, however, unexpected benefits. Having the faculty and peers observe the students in real time led to excellent discussions and feedback on communication and history-taking skills, where everyone was able to learn from each other. Standardized patients were able to add their perspective in real time and participate in the feedback discussions as well. Students were in the beginning of their learning, so we were able to ensure that cases met their current abilities and matched the content they were learning in their other classes. This is in contrast to the extreme variability and complexity that can occur with real patients. Although we lost the ability to do the physical exam, we still asked students to brainstorm what exam maneuvers would be indicated and had them talk through their approach. This led to a better understanding by students of the purpose of specific maneuvers. Faculty were then able to give verbal answers to what the findings were, so the students could use these results in their medical reasoning. Faculty were also able to lead discussions about differential diagnosis and medical reasoning in real time. What were we unable to fix? We tried a number of ways to work on the physical examination maneuvers, including having students examine a friend or family member over Zoom while being observed by senior students. In the end, we did not feel like we could give authentic and useful feedback on the physical exam, so we deferred physical exam assessments until the students returned live to campus. In the fall of 2020, students were allowed to return to campus for some live in-person events, but in a much more limited capacity than previously. There were restrictions in the number of people who could gather in a space, additional time requirements added for room disinfection between learners in the simulation center, and a severe limitation in the time with actual patients to minimize the risk to students and patients, as well as to protect the personal protective equipment resource. We realized that our time in person would need to be maximized. This led to the need to consider even further innovations in the way we teach this course. One solution was to find ways to maximize the learning for our in-person sessions. Prior to the pandemic, we would assign pre-work to be completed before each session. However, it seemed to be deemed optional by students, leading to valuable live time being consumed with educating on the basics. Students had told us that the previously assigned pre-work was not very engaging or efficient, and we worked to improve our pre-session work to ensure that students were as ready as possible to participate, and when they did get a chance to be live in person. Here are some examples. We designed online asynchronous virtual cases for students to progress through. Each case evolved over 5 weeks, stepping students through the approach to various clinical skills. Faculty oversee groups of 12 students who work together to think through the case and the approach. Students were asked to participate in interactive discussion boards and group projects. One example was of a 16-year-old boy who presented with pain with urination. As a team, they grappled with topics such as what is the differential diagnosis, what are the laws regarding treating minors, and how do you take a sexual history with sensitivity. This is an example of a quiz where students considered the various challenges that would accompany this particular case. Students then watched a simulated video of a faculty member interviewing the patient. They were asked to provide constructive feedback on the communication skills used, take notes as if they were obtaining the history, and use the information retrieved to think through the differential diagnosis. We were also able to weave in discussions about prevention, social determinants of health, and health equity. This is an example of a discussion board where students were asked to consider confidentiality in minors and how this may impact this patient's care. Next is a discussion board where students share their concerns about delivering a diagnosis of a sexually transmitted infection and share ideas for best practices for this communication challenge. There are a number of advantages of these online cases. They were asynchronous, so students could work at their own pace. Participation required working on other essential skills such as teamwork and providing feedback. Faculty can guide discussions and interject only when needed. And they allow for more consistency in teaching and more integration with other courses. For example, this module worked to connect to their anatomy lessons as well as classes in healthcare policy and behavior change. What lessons were learned? Having a synchronous component where the students and faculty could engage and review the lessons for the week would have been valuable. It's important to ensure that the cases progress in complexity as they move through them. Students want new and more difficult challenges as they're progressing through our curriculum. Next, we'll discuss our online physical exam pre-work. Early in the curriculum, students need to learn the basic physical exam maneuvers. There are a number of online resources currently available, but there's issues with consistency, ensuring that they're up to date and reflect current best practices, and many of these are overly detailed and complex, leading to a lack of engagement for our students. We decided to focus our modules on the skills and knowledge necessary for early learners. Here's an example of the first page of the vital signs module. Students are first walked through a basic case connected to the physical exam skills being taught and provided learning objectives. Next, they're directed to watch short videos highlighting each specific maneuver. In many of the modules, there's also a full video which demonstrates how all the maneuvers would fit together in a real exam. There is a section that explains to students how this information would be communicated in a medical document and oral presentation. And finally, there are quizzes where students can check their own understanding of the content. Feedback from these have been excellent, and we will continue to use these moving forward. In summary, we were able to adapt some of our prior lessons to the virtual environment and create new virtual learning tools that were more engaging and efficient for our learners. My main takeaway from this experience is that more isn't better, better is better. We all likely have materials that are not as efficient in teaching as they could be, and ways we could maximize the learning in our sessions that do occur. So thank you for listening, and I hope this will help inspire you to think of ways to adapt your own teaching.